All right, I think we're going to get started. I wanted to thank everybody for coming this evening. My name is Kelly Kaiser, and I'm with the Intercommunity Health Network Coordinated Care Organization. And this is one of our public meetings. We have one in each county every year, so we appreciate you coming. We appreciate you coming. If you were planning on coming in January, you may recall we did, due to the weather, do a little postponement. So thank you for coming back again. On your table is our agenda for this evening, as well as some yellow question cards that we would be happy to take during the meeting and follow up with if we can, or follow up with afterwards as needed. And then we also have Ana Luz here, who's doing Spanish translation for us in the back. And so if that's a service that you need, please check in with her, and she'll be happy to help you with that. The restrooms are down the hall and down the hall to the right. So those are, just want to point that out as terms of housekeeping. So I think we're just going to kick it off right now, and I am going to introduce Kim Whitley, who is our Chief Operating Officer, who's going to talk. Oh, there she is. Who's going to talk about our first presentation. So we're going to go through a couple of presentations around some of our projects and pilots we've been working on, and then we're going to open it up for question and answer. So be thinking about those questions as we talk about some of the impressive stuff we've done. So, Kim.
Thank you. So historically, when I've come before you, okay, right there. All right, good. Historically, it's in a weird place. Okay, try that. Historically, when I've come before you, I've talked about different pilots that we have forwarded through a transformation group within the CCO. And today, I'm going to talk about something a little different. Within the transformation work that we're doing within the CCO, we're also doing things called alternative payment methodologies. And we have a work group that works on good ideas and forward thinking related to alternative payment methodologies. So what is an alternative payment methodology? An alternative payment methodology is a way of changing the way providers are paid, changing from a fee-for-service or like a cash transaction basis, meaning they is that? Okay, that's really odd. So, is anybody else hearing the bugs, or is it just me? Okay, so in a fee-for-service transaction, the provider does something, like gives you an immunization, and you give them money for that. That's called a fee for a service. An alternative payment methodology is changing the way you pay providers, and you pay them for a value or an outcome that they achieve. And so we have a work group who's been working on how do we take this new approach out to the community and start to contract with providers in a different way to achieve outcomes. And I'm happy to present today Phil from the Council of Governments, from the Lynn Benton Lincoln Council of Governments, who was our first alternative payment methodology. Through this payment program that we had with him, if they kept their costs under a certain amount while maintaining the service level, they got to retain the savings from that. But there was a caveat. They had to reinvest those savings back into IHN-CCO members in a way that was beneficial and enhanced the service delivery system. So I thought I'd have him come up and talk. We have a small video, and he's going to talk about that and talk about the program.
Thank you. Thank you, Kim. So is that close enough for me? I'll try and be loud so everybody can hear really clearly. Before we hit play on the video, I'll tee that up a little bit, but I wanted to add or build off of what Kim had introduced and talk about what the program that we use that alternative payment methodology on. On that trifold reader board back there, you can see a lot of the different services that go into it. One you'll notice on there is labeled RideLine, and that's the non-emergent medical transportation. We've been coordinating it for the 3-county region for about 11, almost 12 years now. And as the Affordable Care Act was rolled out and the population expanded, and as the IHN-CCO took on responsibility for Medicaid members within the 3-county region, we had that alignment. We started meeting really early and kind of expressed what that meant to them, that they were taking on that responsibility of what we were doing. We quickly decided we would go ahead and do that contract, and started right off from the get-go with that alternative payment methodology. And to put in terms of what the volume of service that's coordinated through that program is when we started 3 years ago, three and a half years ago with the contract, we were coordinating approximately 6,500 trips per month to deliver Medicaid recipients to their medical services. And today we average a little over 17,000 trips per month. So the volume of business that we're coordinating, and then the funds that are providing that service and tying into what this service became, are all wrapped up into one. So Pedal Corvallis is one of those types of programs that you have these brainchild conversations for a while and say, wouldn't it be great if, and then you fill in the blank with some of your aspirations. This is one that once we realized we were going to have some savings, we said, this is one we'd like to move to reality. And so we coordinated on that effort and got it up and running. And this video will give you an overview of what Pedal Corvallis looks like, and then I'll talk a little bit about the background of it. So with that, Ben, go ahead. The Intercommunity Health Network Coordinated Care Organization and Cascades West Council of Governments partnered to put a bike share program together that would be available to IHN members and the community at large in order to have an additional transportation option and to make getting around Corvallis fun and easy for everyone. In order to make it accessible, we've really considered what all of the elements are needed to make a program successful like this, and removing barriers. This you can text, use an app, or go online to sign up. The way it's structured for memberships is we have 3 different membership levels. There's a 3-day pass, which is only $5, a 1-month pass, which is only $10, and then an annual pass is $25. But those membership fees are waived for the IHN-CCO members so that they can use the system for free at 2-hour increments or less.
I use the bikes almost every day. They're right on my block. I ride it to go to Dixon, I ride it to go to the store, I ride it just for fun. Most of the time it's just for fun.
The way to really experience Corvallis is on a bike. One of the things that we like to do as a family is just go explore the area around us. This provided an opportunity for us to bike together as a family.
There are 6 stations throughout the town with those 33 bikes and 2 trikes.
I have a favorite number, it's 3608, and it's my favorite bike because the seat's always down. I think if I walked there and the seat was up, I'd be like, who was on my bike? Yeah, it's very personal.
Really, it's another transportation option that can link up with existing transit and bike and pedestrian services. So this is a great way for people to engage in something that is becoming really a mainstream option.
I don't have to maintain it. I don't have that responsibility. I just get to go unlock a bike and ride.
They also gave us free bike helmets, like really legit bike helmets.
The Intercommunity Health Network Coordinated Care Organization and Cascades West Council of Governments, we've done a great amount of work so that members can better understand how transportation needs affect their physical and mental health as well. All right, so as I go through some of the things I wanted to talk to you about tonight, I think it might actually be easier if you have a question as we're going through to go ahead and shoot your hand up. I know we've got some time at the end of this and then at the end of the entire meeting, but it might actually be easier to answer some of those questions as we go through, so please don't hesitate to throw your hand up. I did want to talk for just a second, go ahead and advance slide, one more. Wanted to talk about what a Council of Governments is, just very briefly, is that we cover, we're a member organization. Our members are the cities, the counties, the Port and Tribe that are in the 3-county region of Linn, Benton, and Lincoln. And we work on projects that go ahead and next slide. We work on projects that our member jurisdictions either can't do, shouldn't do, don't want to do, or we can do on a regional scale that is more effective and efficient than they can do individually. That's particularly true in some of our smaller communities. And where we have, I think, our sweet spot is where we can work on things like this program at the intersection, puns intended here, of community development and health. And I think the testimonials in that video from the IHN members are really, they say it much better than I could do, but they are talking about they were using it for fun. They were using it for community engagement. They were using it for family. And I think we all recognize in this room how important physical activity is on a daily basis and how important physical activity is related to mental health. And so when you leverage those types of activities and can bring a program like that into a community, it enhances a lot of different aspects of health, not just the part of they have a bike, which is another mode of transportation to get to appointments. Next slide. Council of Governments, Oregon Cascades West Council of Governments, a bit of a long, wonky name, but we are also the area agency on aging, the senior disability services. We provide Benton County Veteran Services. We are an area commission on transportation, so we work on infrastructure project funding recommendations, economic development district, so we talk about jobs, employment, workforce, and the things that tie in with our sister organizations around workforce and affordable housing, which you're going to hear more about housing in a little bit. We also work on projects like Safe Routes to School. So Safe Routes to School are often safe routes for all, and tie again into this type of an infrastructure project. And then transportation options, how do people connect with services, bike, pedestrian, transit, and even carpool and vanpool, so connecting to other communities. Next slide, and yeah. So, as I said, this is kind of the brainchild of bringing these concepts together about what would you do if you could, and then the concept really coalesced in December of 2015, and as you can see here, we actually got this launched in about 6 months, which is a really fast turnaround for a community-based project like this, especially when you're putting some sort of infrastructure in place on other people's property. So there was a tremendous amount of work that happened in a very short time. I've hit on some of these already. The multimodal tie-in is all of the stations are located. I'll show some maps here in a second, but they're adjacent to or very close proximity to transit stops, so that they can connect with transit, as the bikes can be first mile and last mile connectivity where the transit doesn't run. And one of the vendor considerations that we put into this is that a lot of bike share programs are purpose built to be extremely durable bikes, and they get so durable that they are like riding a Sherman tank. So you can't really lift that bike and move it somewhere. They're over like 100 pounds. These bikes are quite a bit lighter. These are really more of a step through. They're the breezer style bike, and these can be put onto the city bus bike rack and be taken between stations that way as well. I think we can go to the next slide. So when I said we did a lot of work really quickly, we did some analysis on station location considerations, had a stakeholder group, took existing client Medicaid transport data that we already had in our non-emergent transportation system, and we did a heat map of that and overlaid the heat map of, this one is the origin, so where the trips were starting kind of from the home kind of consideration. Once we had that picture, next slide, we looked at where the majority of trips were in Corvallis, the destination side, and those are, you probably recognize the two brightest spots is up on the hill for Good Samaritan Regional Medical Center and 27th for Benton County Health Department. And so that's exactly what we did. Is next slide, there we go. We located our stations adjacent to transit at those hot spots where they kind of overlapped. And so the Samaritan Square Sam Fitz station is the one on 9th Street. That's probably one of the most visible that people first notice it at. The Benton County Health Department up on 27th. Lincoln Health Center is on South 3rd Street. The Downtown Transit Center, which is on 5th. Osborne Aquatic Center, of course, at Circle and Highland. And then the Oregon State Credit Union, the one on 9th Street. That was before they opened the new building. that's the overlay of where those kind of all stacked up in the station locations. Couldn't do this without sponsors. So in addition to reinvesting those savings that we had, we've actually had sponsors buying into the system. So they're sponsoring those stations, sponsoring those bikes for the operational costs. And one of those, yeah, we covered rates. Rates was in the video. Here is the breakdown again. I want to kind of point out a little bit of this is that if you break that down, that's like $2 a month for the community to be able to access it if they're buying an annual pass, and then they can use it essentially for free beyond that as long as they're using it in two-hour increments, and you can use it multiple 2-hour increments in a day. So we based all of these decisions on US best practices that we saw for applications of bike share programs in the state, and using a time window of could somebody reasonably be able to ride pretty much anywhere in Corvallis in about a half hour, have an hour for appointment, and then half hour back and still be within that window. They can check it back into another station if it happens to work out that way as well. But hopefully the intention is that an IHN member would be able to use it to access an appointment and never have to have a charge. So unlimited access to IHN for free. Questions about that? That's usually where, okay, there we go. Payment is made with signing up on the front end secured with a credit card, and then any overages of time. So if somebody does go over, it's $3 per hour, and so then that goes on to their debit card, and they receive a receipt at the end of the ride.
Don't many Medicaid patients not have credit cards?
Oh, so the unbanked, is that the question? Like if somebody doesn't have any sort of a credit card to tie it to? That's been a question, concern, and a consideration that we took from the start of the program, and found that it is a relatively small portion of the population. We've been looking at different strategies that we can try and implement on a cash-based system, but trying to tie so that there's the security of if somebody were to actually sign up under a false name, take a bike, and disappear, then how do you cover that loss? So we haven't worked out our system to get around that yet, but there are some programs that are doing it in, I think it's Vancouver, British Columbia, and a pilot in Philadelphia where they are using a cash-based system that somebody that is unbanked could still have access. So we don't have it figured out yet, but we are working on trying to get that into the system.
How would an IHN member get signed up for free membership?
Great question. So the question is, how does an IHN member get signed up for the free membership? So all of the materials, and we've got some of the materials that are on the back table, they call the Cascades West Ride Line, then non-emergent medical transportation brokerage, receive the information on how to sign up, and they're given their access code for when they sign up to give them the free membership, and it puts them into their own category of IHN membership. And we help to walk through that process. Another element of some of what we've done through the reinvestment in the transportation services is we have actually introduced mobility management and travel training. So if somebody doesn't know how to use the bus, doesn't feel comfortable, needs some training, that's another piece. And so this kind of fits into that realm of assistance, is to make sure that somebody's successful being able to sign up and use it. I think I have got a note somewhere else down the road here about this, but I'll mention it here is that we even have some interns that are helping us right now from OSU, specifically trying to make sure that the word is getting out to the IHN membership, and not just getting out, but how do they use it and know that it's for them and what all benefits it can provide to them. And as a part of that, one of the suggestions that they had was to have to publicize some drop-in clinics at stations. And so this is great. This is where you get fresh ideas, something we hadn't actually had on our outreach list, but to have a couple of times during the spring when the weather gets a little bit nicer, that they can have a couple-hour window so that somebody can come by a station and there will be somebody at that station being able to show them how to actually operate the bike and how to do this checkout and everything along those lines. All right, so utilization so far, there are currently 90 active members, of which 40% are IHN, so we'd like to see that number getting a little higher. There have been 215 members all time, and we've been actually a little surprised at how many people have been using it with the 3-day pass. So we saw a big surge, so we launched June 30th, right? So we saw a little surge right around 4th of July, thought maybe that was more of just the introduction of the program. Thinking now that around the holidays when people have come in to town for other events, they've actually been grabbing a 3-day membership. So that's been interesting to see. And then 1,136 total trips taken so far. One of the things I would say is that compared to communities our size that have bike share systems in place already, our total number of registrants kind of per capita is a little bit lower than the average, but our utilization of members that sign up is almost twice that of the national average. So the people that are using it a lot. So that's good. We need to now do a little more analysis of how we get the total number up, and then what does that mean for the engagement that people are using it a lot. As it was mentioned in the video, we did have bike helmets generously donated by the Mid-Valley Bike Club, and then we purchased some as a part of the initial launch that we could give out because we wanted that safety aspect to be forefront of using a bike system. One element of how that then is worked out is that we have, anytime somebody contacts us that is an IHN member and is going to be signing up, they're contacting us to get that code for signing up, and we screen them at that point to say, do you have a bike helmet? And if they do not, we're offering to provide them with one. And then this is where the community and economic development side of what we do kind of comes into play. Is we said, well, who can get us the boxes to mail those helmets out to the members? And we actually found a local box company that could make the boxes for us and do it cheaper than what we could get them for, like at Staples or something like that. So again, we're still circulating more of that community support, community money back into the local community rather than shipping it out to a box store. That, I think, covers that slide. Why this vendor? I already talked about the weight of the bikes is one consideration, but really it was their full turnkey service that they provided that attracted us to them and made that selection, the final selection, pretty easy. Otherwise, the cost of this program was a lot less than what some of the other upfront costs were from other vendors. Next slide. There are the bike racks and or docks that they lock to have the 3-point security, so the bikes aren't in kind of like a wheel bender type of bike rack, and they're secure and stay upright and don't tip over easily. And I understand we had a near miss with the 9th Street station with somebody that had a medical emergency and just barely missed that station. It's all good? Yep. All right. These bike racks, so this is another part of when you bring in a community project like this, you have to work out all these details, is that bike rack it deviates from what the city's standard is, so we had to get a variance or an exception to the city bike rack standard. Another part of this is that having the ability to unlock the bike or get the code to unlock the bike via text message. A lot of, I forget the numbers now, I think it's something in the mid to high 90% range of IHN Medicaid members have a cell phone, but then it drops off by the number of members that have a data plan. And so if they can't use a direct app, they can still do it with a standard text message. They text to the vendor texts them back instantly with a code to unlock that bike number. The bikes are very comfortable, very upright. They've got a basket, 8-speed. They've got the fenders on them so that it can be ridden in all weather. And they do have front and rear lights so that they're fully compliant. An update note to this is that the company is already looking to upgrade to another version of the lock, moving away from the U-lock to something that is a little bit more flexible and doesn't potentially get lost off the bike if they somehow jumps off the bike out of the basket, or they drop it or whatever. And when they first came to us, these bikes had a different gear mechanism, and they were experiencing that some of them were having problems. So they actually came through at no additional cost and changed out all of the Shimano gear mechanisms. And rather than tossing them or trying to resell them, they actually gave them over to the Community Bicycle Collective here. So that is, again, really good to see the stewardship that they're doing. Next slide. They also provided or hired a local mechanic, so somebody that's in the community to do the maintenance on these bikes. Our contract with them says that they will basically physically touch every bike like 24 times within the year, and so twice a month. And I think our December numbers were that the bike average was that they were checked 5 times a month. So we're doing really good on the routine maintenance and have had very little issues with maintenance. We had somebody that their U-lock, they couldn't get the function to work all right the other day. And so it was at the Osborne Aquatic Center. They actually went in and talked to staff there, and they said, well, just leave it with us. And then we got the Zagster, the vendor, the information, and they had the mechanic out there that same day to pick up the bike and service it. So really, really good responsiveness. Haven't really had any loss or anything yet, so that's good. So insurance has been no problem. This is kind of the steps. I've kind of described it already. You either text or use the app to get a code to unlock the bike. You put that code into the box on the back. The key is for the U-lock is in there on a retractable thin cable. You unlock it, put the lock in the basket, or in it kind of has a holster on the back of the rack. Ride, you can lock it up, and any bike rack in the city, this is another part of why we liked this system originally, is that any bike rack in the city becomes a layover point. So you can make multiple stops, you can go in places that don't have to have a station. That allowed us to put in fewer stations on the front end and have a very robust system for where people could stop. And then when they return, they lock the bike up, they put in the code again and say end ride, and it tells you how long your ride has been. It gives you immediately the cost feedback if you had gone over an overage, or it shows you 0. And then it emails you all that information as well, so you've got kind of the receipt of your ride. Questions on that section? Sure, I'll take a quick stab at just saying this isn't related to those other programs, but I'll hand it over to the CCO folks to address that specifically.
So we're rolling out alternative methodology, payment methodology contracts to all providers, and all providers will have the opportunity to make decisions about how to reinvest dollars that they earn for making positive outcomes in the healthcare of our members. So the contract that the CCO had was just with the Cascades West Council of Governments. They earned extra dollars for doing a really good job in meeting the needs of our members related to non-emergent medical transportation. And then they got to propose a couple of different ways to reinvest that into IHN-CCO members. And the one, and you reimbursed it in this, and then you mentioned another project, and didn't you do a third?
There was member coordination.
Member coordination, and for anybody who's ever struggled to get to a healthcare location without a way to get there, the ability to work with a community partner to coordinate for that member so they get there efficiently and on time, and then to recognize after the visit, are there additional things that they need that they wouldn't otherwise get if somebody wasn't there to help them understand the next steps and how to get their needs met. And so the coordination and collaboration that this brought to the community and the partnership between the CCO and the non-emergent transportation is not going to stop. It's just going to get bigger as we work together to really say, how can we address the needs of our members, reduce the gaps in care that happen when members go from one place to another and don't have the transportation or ability to get there. And so I'm looking forward to doing a lot with the COG going forward, and as our non-emergent medical transportation program evolves.
I don't think I got an answer to the question. What's the best way for the public to see into the decision-making process that would choose this very worthwhile project over other very worthwhile projects?
Did you want to answer?
So I think, Dr. Huntington, I think what you're after is on these decisions, how are they made in terms of when we negotiate with a provider and decide how to use those dollars. So from a provider perspective, in terms of our contracting, those decisions are made between the CCO and the provider, and then we talk about them here at our public meetings. We talk about them at our Community Advisory Council meetings and present what's going on there. So I think it is a contractual thing, but we do go through what we're doing and how we're reinvesting those dollars back into the community. Around your question around how do we decide how to use dollars for different things and whether there's different needs, we have different contracts with all of the providers, including Benton County, and so we work with them on a contract to figure out what information they need or what dollars are needed or what dollars are available to take care of those members. So it's not all one big thing, it's individual contracts with various providers who offer different services. So it's kind of it's a great question. It's kind of a complicated question to answer because it's a contractual relationship with different providers.
I would just have for more public participation
Sure.
and visibility in these decisions.
Okay, I hear you. Thank you. Yes, sir.
Yeah, I would second what you're saying, just because IHN is, administering a public benefit here, and so it's not a private actor; it's a government. In this realm, it's acting more as a government actor, and so I think for the public to feel like it's they're empowered and they know how the decisions are being made.
Yep.
Goes along with what the role is of IHN.
Sure. Go ahead.
I hate to take a comparative view because I'm very much in favor of transparency, but the typical pay-for-performance contract, if you go under budget and you realize some savings, you can typically use those for your organization anyway. So I guess what I'd say is that the COG and the IHN-CCO in their dealings have decided that they would give the IHN-CCO some sort of control over the projects that they chose. But I think if my organization, for example, saved the money, we would want to be able to float some projects that made sense, kind of worked with the community needs as we saw them, and then we have the input of the IHN-CCO. So I guess what I want to say is there are a couple of ways to look at this, and I feel pretty comfortable with this and pretty pleased that the COG invested in this. It's a cool project, which is not to say it's the only cool project.
Well, I think back to your point, one thing I'd like to point out is we definitely want people to be involved and engaged, and we have a lot of opportunities to give that and share that feedback. So I hope to hear more from you about that. Are there any other questions for Phil, or did you have more?
I got one more slide. Next steps. So trying to look for additional sponsor recruitment and expanding this system to the OSU campus. So I'm pleased to announce that we do have an IGA now with an intergovernmental agreement with OSU to begin that work. We're hoping that in the next couple of months we'll have 2 stations with 8 more bikes added to the system so that it starts to engage with the campus even more. That would bring the total to 8 stations and 43 bikes in the system. I think that in the video it had mentioned trikes, and I really wanted to also add to that the trikes were again a consideration of the ability to move a little bit more on the bikes in a safe cargo kind of capacity, not just overflowing the front basket, and also for members that may be physically capable of pedaling the bike but have mobility balance issues and things along those lines. So that was again a consideration that we put in on the front end, and the home of those, if you will, is the 2 health center stations, but they do tend to move around the community, and then they're periodically moved back if they don't find their way back to those stations. That was the conclusion of my prepared statements. If anybody has any more questions, happy to entertain them. All right. Well, thank you guys for your time.
Okay, so our next program is to talk about how housing affects health. And we have Brigitte Olson here with Willamette Neighborhood Housing, and she's going to come up and give us an update on how things are going from that perspective. And then we will be happy to take questions and answers with her as well, and then we'll have a time for broader questions and answers at the end.
Great.
Thanks.
I'm shorter than most folks. Thanks for having me. Again, my name's Brigitte Olson. I'm the Deputy Director
There you go.
at Willamette Neighborhood Housing Services. And our mission, we're committed to improving lives and strengthening communities through quality, affordable housing, homeownership, economic opportunity, and community partnerships. We're celebrating our 25th year. We've been around, and we were founded by the city of Corvallis back many, many years ago. And since that time, we've expanded our service area. So we serve Lynn and Benton counties for our homeownership development activities and Lincoln County for homeownership promotion. We own 382 units of affordable housing in Lynn and Benton counties. Just last Friday, we finished, and folks got to move into our newest development in Northeast Corvallis for veterans. So 8 veterans got to move into a new home that took many years in the making for us to achieve. But one of the gentlemen who's a veteran, we now have a big school bus outside of one of our units because he was living in his bus for a long time until we were able to find him housing. He's now living in one of our units and is happy as can be. So it takes time to develop our housing. We're in a housing crisis in the state of Oregon, and there's much more need to be doing more of that throughout our state. So we develop affordable housing. We also have asset building programs. We have homeownership center where we teach folks about managing their money, buying a house, and then if they're having issues making a payment on their mortgage, avoiding foreclosure, and negotiating mortgage terms with a lender. Next slide. In recent years, I guess recent being the past 6 years or so, we've become the convening organization or lead organization behind the Lynn Benton Health Equity Alliance. So we're a group or alliance of multiple organizations all working on upstream strategies to keep folks healthy in the first place. We know that a zip code defines people's health outcomes over time, and that's not okay. And so as a coalition, as a group of folks, we're working on barriers and policy and system change to make sure everybody in our community can be healthy. So examples of some of our work, we started with the Benton County Health Department. They were the brainchild behind this initiative. Since that time, Willamette Neighborhood Housing Service has taken on the coalition guiding and convening, and we get money through the Oregon Health Authority, disseminate it out to other community organizations. We've been working on tobacco-free housing, leadership development with community members, wellness councils in the schools, dental kits for kiddos, and healthy homes initiatives. Next. Other work that we do that's regarding health and upstream health is we're really focusing in targeted neighborhoods, knowing that when multiple organizations all work together and have a common goal, you're able to achieve more. So it's called collective impact. And so for about 6 years, we've been working with many different other organizations in the region, including Benton County Health Department, City of Corvallis, and the like, and really having a complete South Corvallis, knowing that Southtown is a lower income neighborhood and has many access barriers because it's away from downtown, although not far. The path or 99 doesn't feel safe for people to walk on. There's not an easy bicycle way for people from downtown to get to Southtown. And so we've collectively been working together on creating policies and opportunities for the community. Willamette Neighborhood this year, or the past couple years, has been really doing more grassroots organizing with community members to see what folks want. What do folks want in Southtown to have a healthy community? And many of the things that keep on coming up and again within community members is people don't, Southwest 3rd is unsafe, Lincoln School is right on Southwest 3rd, dropping off kiddos to their elementary school. Parents and kids don't feel safe. Speeds are really high on that street. There's no full-service grocery store. There's no financial institution. There's no medical services besides the Benton County Health Department, which is a great asset right next to the elementary school. But people are lacking resources and are really working together from a grassroots level to try to bring about positive change and find financing tools and the like to make that happen. Next. So we do what we do because home matters. You know, I think about my family and what home means to me. I have 2 kids at elementary school, and at the end of the day, you know, I look forward to sitting around a kitchen table with my kids, sharing their days, their successes, their failures, and sharing a meal together. And home matters to everybody, and I go to work every day because everybody should live in a safe and stable home. Everybody should be able to thrive and be surrounded by a community that cares. So we know, you know, some concrete things about healthy habits take root more easily in stable, affordable homes. Children in stable homes learn and achieve more in school. When a kiddo is going and living in the same home year after year, going to the same school, building relationships with the same school teachers and the principal, they're going to do better in school. And so stabilizing people's lives by affordable housing is critical. Next. So I should have made the links between housing and health a long time ago. I was a Peace Corps volunteer in maternal and child health in Morocco and working on HIV/AIDS education in Kenya. And then I started, you know, working in affordable housing, and my 2 careers are now meshed. But there's a lot of great work happening in the state of Oregon associated with health and housing. There was a core study up in Portland that included 145 housing properties with 3 different housing types. So it was family housing, permanent supportive housing, and senior housing for seniors and people with disabilities. And what they did is they studied the long-term effects of people's health when they get into affordable housing. Key outcomes that has been proven is primary care visits went up after moving into affordable housing. Emergency department visits went down. Primary care visits went up by 20%. ED visits or emergency departments went down by 18%. That's a huge cost savings and better health for the residents. Residents reported that they had access to care and quality of care improved after moving into housing. Fantastic. And then integrated health services were a key driver of healthcare outcomes. And you know, I think as I've worked at Willamette for 14 years, some of the key learnings I've taken on is learning that cross-sector partnerships matter, and you can do a lot more when you're working across different sectors. And so healthcare and housing are critical to stabilizing people's lives, keeping them healthy in the first place. So our pilot with Intercommunity Health Network included 2 components. One is health navigation services that connect residents to healthcare and social services to be delivered where people live. I had this hypothesis that people are going to be more apt to participate in services near them. You know, if there's a community room that's 2 doors down, opposed to driving downtown or getting on a bus and trying to engage and figure out parking and all that, people are going to be more apt to participate in certain programming. And that takes time, and I'll talk more about that. The other component, so that was health navigation services, I'll talk more about that shortly. And then the other component was health and housing planning. We, as a housing developer, want to do a better job. We're doing a good job, but we want to do a better job of incorporating other ways to deliver services through either healthcare at our housing, best practices for senior housing, and how to coordinate those efforts and bring in the supportive services directly to our residents. So we're looking at a health and housing plan that's focused on senior and permanent supportive housing for residents. Next. Our project goals were to increase utilization of preventative health care appointments, much like the core study, enter into an MOU with healthcare providers to deliver on-site programming, and then to develop the health and housing plan. And so the navigators or community health workers build relationship with our residents and offer one-on-one coaching to address health concerns. They're working on community building to engage with the neighbors, learn about medical services, and address physical and mental health wellness. The services are based on each individual property and community's need and individuals. So example in Corvallis is we own Lancaster Bridge, which is in northeast Corvallis. And there is food insecurity concerns during the summer months. So what we did last summer is that we offered school lunches in collaboration with the school district and USDA. And after that, free summer lunch program that was provided on site in our community room opened up to the greater community. After that, we had kid wellness programming and activities. We did hikes around Jackson Fraser wetlands, which is really in everybody's backyard, and really trying to engage the kiddos at that property in wellness outcomes and programming. We've also worked on writing groups at one of our properties. So we own the Julian Apartments in downtown Corvallis, and wellness programming at that property. And it really is specific to each different property. Each property has their own resident leaders that we work on developing those resident leaders over time, and the health navigators add the support to help them be successful at engaging the community. Other component is housing stability. So eviction prevention services. We offer financial education to our residents and the wider community. We'll take $50 off of people's rent if they participate and graduate from our Dollars and Cents workshop, knowing that when you learn how to manage your money over time, that will help add personal assets and wealth over time. Next. So some of the successes, not only did we have MOUs, but we offered dental screenings. We kept on hearing from our residents. They were really concerned about dental care, access to dental care. And so we had a dental screening in collaboration with Benton County Health Department. It was offered at one of our co-sponsored sites, Corvallis Family Table, which provides a healthy takeaway meal for families in South Corvallis that's offered twice a month. So we have the dental screenings there. So you go where people congregate already. You deliver added programming, and it was a great success. We had loads of folks coming. We had people from Lincoln County wanting to come over and get the dental screening there. And then we also offered it at the Hotel Julian Apartments in our community room. And then we've also been able to do barrier-free yoga. So adding a yoga class. This is across from Lincoln School. This is our Alexander Court Apartments. We co-located with CardV. So the yoga is at CardV. We have childcare that's free and accessible. Residents are able to get this free service, and then with childcare provided. And then the housing stability. Actually, we've been able to help 17 households with eviction prevention services that helped stabilize their lives. And sometimes that means talking to the property manager and feeling what kind of barriers they're having. Sometimes it means finding emergency rental assistance. Other times it means there's a crisis in somebody's life, either mental health, and we're trying to link them up with appropriate providers to make sure that they can stay in their home. Other successes is the entryway. This is the entryway of the Julian Apartments. Through some of the community building efforts and leadership development, amazing artists live at the Julian. Last summer they had an art show to show off their work with their community members, and pretty amazing artists that live there. Next. And then individualized assistance. So we work individually with people one-on-one to address their concerns. And that takes time. Just as human beings, it takes time to get to know somebody, to open up to somebody. And when we got awarded the pilot, it takes a while to get to know the residents. But over a couple months, one of our health navigators kept on coming to a property week after week, hanging out. And all of a sudden, a person who she'd interacted with for a long time just came up to her and said, I think I need your help. I'm not able to do everything I can do. I'm not able to survive happily in my apartment. It's exhausting for me, and I need extra supports. And through that relationship, our navigator was able to link up with the Council of Governments, government's senior and disability services, get some home health care support, 20 hours a week in her home. And she realized that she had been really exhausted and depressed and needed mental health services. And through a couple more months went by, she started coming out more of her apartment. She started realizing that she had amazing assets. She started organizing the community members and get social gatherings and cookie gatherings and really bringing up her concerns to her residents and talking about it. She now wants to work on an emotional toolbox that she can help people identify sort of their challenges with mental health, which as a society we don't do a good job of talking about, which I love that she's bringing this forward. And working with the residents. So she's been an amazing community leader who's thriving and happy and stabilized. And then the last slide is just a little more about our health and housing plan. So we've learned a lot hanging out with public health people, and I'd like to say I'm almost a public health person now too. And we want to develop new affordable housing in the future that links up with many of the supportive services that we know people need to thrive. And so that includes, we're going to be looking at senior housing, maybe senior co-housing in the near future development, and what kind of best practices are out there in the nation and worldwide that we can bring to our properties, to bring to Corvallis. And then the other component is supportive housing. Too many people in our community one person is too many to be homeless in our community. So right now we want to do a better job of identifying some of the financial resources to help, one, develop more affordable housing, two, when we develop it and get folks who are formerly homeless into their housing, get them the proper support so that they can be successful and stay there. Questions? Our waiting lists are a problem, in the sense that we have a long waiting list at most of our properties. I would say we urge people to go ahead and get on the wait list because the wait lists do move and it depends upon each different property. There's always a need at the state. We're in a housing crisis and we need more money to develop affordable housing, quite frankly. And there will be opportunities tomorrow. Health Equity Alliance, I'll be presenting about how to talk about housing and how the best practices associated with that. And we're hoping to bring a group of folks up to Salem to talk to our legislators about the need for affordable housing in our community. Yeah?
Can you say something about the building that will be built at the site of the men's winter shelter?
I can't because we don't know yet. So the men's shelter, which is on 4th Street, we are looking to acquire that property at the end of the term of this shelter, but we don't have plans yet. We're working on the financing and the packaging of that, but we don't have plans, but we'll be working with the community and of course identifying the population and the needs. But once we know, we're happy to share, yeah. Any other questions? Thank you.
All right, so now it's time for us to have some questions and answer. If there's additional questions that people would like to ask, or if you have a card, we can pick those up. Does anybody have any questions? Ike?
Just to follow the question about how can the public participate more, these contracts that you mentioned sound reasonable, but it is Medicaid money. That's our money. So that's a plug, I think, for figuring ways and inviting us to come to that decision-making process in some way. Now, there's a meeting that you invited me to, we talked about,
Yep.
the 4th Thursday.
Yep. So what he's referring to is we have what's called our Delivery System Transformation Committee. It meets every other week. And Kim is actually the chair of that. So I'm going to have her just give a summary of what it is so that you can have that in your pocket for the next time. Okay.
Well, and I also wanted to clarify. So Bridget, can you stand up for a second? Yep. The pilot she was referring to was developed in a public process. The dollars that went to the housing pilot with the navigators was developed at the Delivery Systems Transformation Committee. It's a public process. You can sit down now, thanks. It's a public process that's available. We start every meeting saying that this meeting is open to anybody who can improve the healthcare outcomes of an IHN-CCO member. We welcome people to come, but the participation really is for those who can affect the health outcomes of our members. We have rules that you have to have been there 5 times in the last 6 months to be able to vote on any decisions. We spend the months of January and February working with people from the state of Oregon, Oregon Health Authority, who provide guidance in helping us determine our scope for decision making. We're in that process right now. Then we spend the rest of the year focusing on how do we transform healthcare in order to reduce the costs, increase the access, and improve the quality. And that is our focus. And so last year, was your pilot awarded funds last year? Late 2015. The funding that we have is dependent on the dollars available. So unfortunately this last year, we weren't able to have a second round of funding because the dollars weren't there. So we have to take this year 1 month at a time and see if we have dollars. But the group that comes is very committed. The focus isn't about necessarily funding projects. It's about coming together as a community to talk about how do we transform healthcare. How do we generate good ideas? How do we distribute good ideas? And how do we collaborate on good ideas? So, and it's every other Tuesday, 4:36. Oh, Thursday. Sorry, thank you. It's not today and it's not tomorrow, okay? The next meeting is February 27th. The February 27th is the day we're going to have the facilitator from the state come and help us work on scoping our strategy. So that's Thursday, and then 2 weeks from then, it'll be the next Thursday, right? So, and then it's every 2 weeks on a Thursday from 4:30 to 6. Yes. I just want...
Yeah, where?
Oh, where? It's at the Walnut building of Samaritan Health Plans. Right there across from Winco, right? It's in that corner. Okay, and you just have to walk in the front door and say you're there for the Delivery Systems Transformation Committee.
Is that 4:30?
It's at 4:30, right? So I just wanted to clarify that the dollars that went to the non-emergent medical transportation were part of a proprietary provider contract. Once we sign a contract with a provider, those dollars are no longer ours. So they belong to the provider, they earned those dollars. And that's why that's not a public process, because it's not our dollar anymore. So, any other?
Has any thought by IHN-CCO been given towards thinking about addressing bed bugs? I'm not sure if it's a strong enough nexus to
bed bugs.
Healthcare, but
I wish we could solve that. My son lives in bed bugs at Portland State University. I am so into solving that problem. Because he can't come home until I solve that problem. I mentioned the state of Oregon coming to help us scope how we look at this. And so we, under our contract with the state of Oregon, we have to focus on the 8 elements of transformation. That includes alternative payment methodologies, the development of primary care homes, the integration of dental health and mental health into physical health, quality incentives, health equity, non-discrimination, EMR, electronic medical records, right? The other thing that we need to focus on is our community health improvement plan. So in our meetings, we not only focus on the 8 elements of transformation, we also bring in the elements of the community health improvement plan that we as a CCO collaborate on with our community advisory councils. We also are focusing on the metrics that bring in extra dollars into our communities. If as a CCO and as a provider community, we achieve certain metrics, we get money from the state to reinvest in our programs. And it's actually under that model that we are then developing our own alternative payment methodology with providers.
But I don't think bed bugs have been brought up as an issue.
Well, bed bugs would have a hard time finding a nexus in those.
Well,
right.
I mean,
yeah.
You can just,
Yeah.
I mean, like, if housing affects health,
Sure.
bed bugs leave. Like anybody with mental
Right.
health issues, generally they're the ones
Sure.
that are going to be evicted for bed bugs.
Well, and you hit the nail on the head. The issue, and this is why we have the Oregon Health Authority coming in and helping us scope the conversation, because when you think about what affects a health outcome, everything affects health outcomes. We talk about social determinants of health affecting health outcomes. That's housing, food, security, connectedness in your community, your social relationships, where you live, how you live, all those pieces. And so it doesn't end. And as a community, in order to be effective and move forward and make change, we have to align around common agendas. That's really difficult. And so that's why we have the state coming in to really help us scope. And to date, bedbugs has not been in that narrow scope. That's aligning us and moving us together. Not that it's not important, it is, because we can connect the dots everywhere. Yeah.
What else? What other questions do you have? Yeah.
How are things going with
Oh, so the question is, how are things going with the metrics? So we have finished 2016 in terms of that is the calendar year that looks at the metrics that would be available for us to get dollars back in 2017. And we are still working with the state to finalize some of the data, but we're feeling pretty positive and really meeting quite a few of them. We're feeling good about the fact that we will end up very similar to where we did last year, so with a positive outcome, but we won't know for another couple months specifically until all the data is collected by the state. But we are feeling good about that, and I think the most important thing to say about that is that the energy created around meeting those outcomes and the provider community and what they've done to come together to meet those is really gotten momentum over the last year and continues to have that momentum moving into 2017, which will be then improving the outcomes of our members, which is the goal of that. So we're feeling good about those, but we won't have the final information for another few months. Good question. What other questions? Yeah.
Can you talk a little bit about what you see the IHN-CCO's role is in addressing the social determinants of health, poverty, housing?
I think a lot of my response to that would be that, again, back to as we've already heard, we have a contract with the state of Oregon to take Medicaid dollars to take care of healthcare services for Medicaid members. There's no question around everything that touches health and impacts health. And so I think as we work with our Community Advisory Council and we work with our delivery system transformation and we make sure that we recognize and do our best to address those social determinants of health, how they fit into the 8 elements of transformation, the healthcare delivery system. Our job is to figure out how to bring those pieces together and recognize those and maximize the resources around to help with that. But we can't, again, back to scope, that's not something that we technically have a contract to pay for, but we recognize from a transformational perspective the value that addressing those brings. So it's not a one-to-one, but it's something that's very much in the forefront and something that we want to work on with our community partners. So it's hard. It's a hard one. It's kind of like housing, certainly supporting housing, but we can't build housing. We don't have dollars to build housing, but what can we do to collaborate with those housing units and, as we say, build the sidewalks where people are as opposed to where we are. So it's an ongoing area of focus. Yeah.
How do you determine how you're going to spend the money that you may or may either have or be able to get for flexible services?
So we have a flexible services policy that has been developed and that is approved by the state of Oregon to try and figure out how to use some of those dollars. And so that's part of a lot of the discussion happening at the state level as it relates to the waiver that's just been renewed and how it's not quite as robust as the original waiver that the state had hoped to put through in terms of addressing flexible services, but it does address some of them.
Can that policy be found online?
I'm not sure if it's online, but why don't you write down your information and we can get you, or Kim will give you her card right now and we'll get you some information on that. What else? Dr. Huntington.
What is your per member per month payment for our 60,000 clients now? And how much of that is spent on healthcare? And how do we find out what's done with the difference between the two?
Sure. So I actually don't know off the top of my head what our member per month is, and I will. Unfortunately, we don't have 60,000 members anymore. There's been a pretty big decline in enrollment across the state, so we're down to about 51,000 lives on Medicaid in our area. Our rates are actually out on the OHA's website. Our whole entire contract is out on the Oregon Health Authority's website, so you can see the rates. We get a different payment in 16 different eligibility categories based on a person's age or different demographics. And so that is all available out there. As are all of our financial solvencies are posted out there, so you can see everything that was spent and where. I will tell you that we spend, basically 90 to 92% of every dollar on medical services, and we have about 8 to 9% on administrative services, which is what our contract with the state says. And that is all available on the Oregon Health Authority's website. There's a lot of discussion happening at the legislature, which is in session right now, talking about many of the discussions we've had around here in terms of transparency, oversight, and all of those pieces. And so we have been working and attending the Oregon Health Policy Board meetings and looking at the recommendations. Representative Greenlick has stated that he would work with the Oregon Health Policy Board's recommendations on how to incorporate those into actual legislation moving forward. And so we've been working within that process, and agreeing with a lot of the concepts and giving feedback on some of the other pieces in terms of how it would be most effective from our opinion. A lot of some of the pieces in there are actually already in our contract with the state of Oregon, and so clarifying that and making sure that everybody's aware of that is one way to sort of address some of the concerns that are raised. But we are aware of that, and there's many things in there that we do agree with, and there's some things that would be more challenging, and so we've been sharing that. So as us as a CCO, we are a nonprofit. So we from our perspective, yeah. So we have not specifically taken a position on that statement at this time. Does anybody else want to add anything? For us, that's not an issue because we are a nonprofit and don't plan on changing that. But so we haven't taken a stand per se. Well, I think I certainly can't speak for the other 15 CCOs, but we have been talking, and part of the way that the Oregon Health Authority originally set up and the CCO legislation was written was that each CCO had the ability to, or each area in the state had the ability to go out and create a CCO and contract with the state of Oregon to deliver services. And that contract did not stipulate the status, nonprofit or for-profit or whatever. The theory being, sure, I don't disagree with that. In the end, that is what was there, and so different groups came together and created CCOs in a way that worked best in their own community, and so that's why it's an important discussion that continues to happen. I think given some of the changes that have happened in the delivery system across the state, clearly that's a discussion item. But from our perspective, we are a nonprofit and don't plan on changing that, and so that's where we are at this point. Thank you so much for coming this evening. Have a good evening. Oh.